Good evening, everybody. I welcome you to our bidimensional monthly session of the ICOI. I'm very honored and pleased to present to you Dr. Guido Sarnachiaro, who received his dental degree from the Universidad de Buenos Aires, Facultad de Odontologia, graduating with magna cum laude. He completed his Oral Surgery Residency Program in the Hospital Internacional de Agudos Eva Peron, and obtained his certificate in Prosthodontics at the Instituto Cientifico Buenos Aires. Dr. Sarnachiaro completed his fellowship program in oral implantology as a part of the University of Pittsburgh Continuing Education Program in Argentina. Relocating to the United States in 2003, he received the USDDS degree from the New York University College of Dentistry, once again graduating with honors, of course. He's currently an assistant clinical professor at New York University College of Dentistry, Department of Prosthodontics. He is lecturing extensively and doing research on dental implants related to biomaterials, and he has lectures throughout the United States and abroad. His topic today, it's something very challenging because this is what we are gonna do and we are doing on a regular. It's immediate tooth replacement therapy. Guido, thank you so much for your time, for your energy and sharing your knowledge with us, with ICOI. And of course, we will be open for questions at the end. Guido, the audience is yours. Thank you.
Thank you, Adi. Thank you for your kind words, presentation, and thank you for the invitation by the ICOI. For me, it's always an honor and a privilege to be invited by this organization where I have strong ties since childhood. My father was past president of this organization in '99, so it means always the world, and it's very special for me to be able to share what we're doing with this group. And always thankful for Ken Judy and your hard work, Adi, and all the people that are part of the organization, Betty, Lucas, who work relentlessly to be able to spread the word and information of implant dentistry all over the world. I mean, I don't think that there's a more relevant international, real international implant organization than this one. So for me, again, once again, it's really an honor and a privilege to be here. And thank you everybody for taking the time off this Saturday. I know that there's people all over the world, so taking the time away from family and friends to spend an hour together. So it's very much appreciated. Anyway, so over the next hour, I would say we're going to talk, as Adi said, about immediate tooth replacement therapy, more important in the aesthetic zone. Before I get into the depth of the presentation, I always like to thank and acknowledge that I'm part of this tremendously skilled and incredible human beings group, which was started by Dennis Sarno over almost 40 years ago now. And it's a group of clinicians, which is a constant learning experience. For me, when I relocated to this country after my program, having been able to be part of this is really gives me a lot of pride. And you'll hear me talking about our cases because indeed this is a multi-specialty, but also a practice that we work things together. And sometimes I do the surgery, sometimes I do the pros, sometimes I do both. But again, this is our joint effort and all the cases we share, and we take a lot of really pride in the things, and we try to do the things to the best of our ability. So having said that, let's get into the real presentation. Before we cover the actual clinical cases, I just want to have a quick overview. This is an article that was written in 2007 by Nick Elian and collaborators, also with Dennis Tarnos, Richard Smith, and Stu Fromm, and talks about a simplified socket classification. Very, very didactic. Everybody can have their own classification as to what happens with when we take a tooth out and we have a fresh socket. This I find that is very, very clear, very self-explanatory. A type 1 socket is a socket that is considered to be intact. All the bony walls and the soft tissue is considered to be ideal. Then we have a type 2 socket, which is basically a socket that has, the soft tissue is ideal, but there's some sort of dentoalveolar dehiscence defect, which can be very tricky to restore. And number 3 is a socket that is basically, there is a defect in not only the bone, but the soft tissue. Having said that, we will only cover the type 1 sockets due to time constraints, but the important thing is what is it that we do and how is it that we approach the treatment with immediate implant or immediate tooth replacement therapy on type 1 sockets. Again, bony walls and soft tissue ideal. So our concept and what we have been working for years now is about an approach that is usually what we call a minimally invasive procedure. And minimally invasive procedures can cover a lot of things, but at the end of the day, we're still taking a tooth out. So are there any ways to be considered minimally invasive? The answer is yes, and we'll cover that in a second. Not only about the minimally invasive aspect, but also how we approach these cases and have predictable approaches or predictable results or predictable outcomes. And the third leg to this concept is that by being minimally invasive, what we want to do is what we find in a type 1 socket after the extraction is done and nature, the gingival architecture is considered to be ideal, we want to preserve it. In other words, we don't want to have to recreate anything. So whatever we find that is considered to be ideal, we want to preserve it to the best of our ability. That's why it's always a sign of please, if we find something that is as good as it can get, just please do not disturb it. So our treatment protocol in these cases on immediate tooth replacement therapy is trying to minimize the surgical interventions, as Peter Worrell and Joe Kahn have described, into one surgery, one time. So we try to condense the extraction, the surgical extraction of the tooth that is failing, and at the same time, that's what we call immediate implant placement. We place our implant and then we allow 4 to 6 months of healing of this implant. So in other words, not only the bone has to mature, but a very important aspect that we've been doing and we learned a lot for the last 10 years is about soft tissue maturation around those implants. And that's why we allow 4 to 6 months of healing. So let's talk about an interesting article published by Georgios Romanos in 2018 and Crespi, which talks about tissue remodeling in immediate versus delayed prosthetic restorations, which is very interesting. And the reason why is because it confirms once again what different articles in the literature have been saying, which is the following, that there is indeed comparing facial tissue level at different points in time from 1 year to 4 years, and also buccolingual changes of the dimension. From 1 year to 4 years, and you can tell that there is indeed differences from a delayed approach in both aspects compared to an immediate. If we talk about facial tissue level, we can see that the difference is about a 1 millimeter of recession, which is a lot if we are able to place our implant and immediately provisionalize and then finish our case versus delaying the case, which we would, in average, as I say, be dealing with a 1 millimeter recession, which in the aesthetic zone is pretty substantial. Now, not only, as we said, about the facial aspect or the recession, but also the buccolingual dimension. What happens when we take that tooth out and if there's any buccolingual shrinkage or collapse? And once again, and we will have other articles that I will mention through the presentation that confirms these findings, that the delayed approach has, in average, 2 more millimeters of collapse, of shrinkage buccolingually versus the immediate implant therapy with an immediate provisionalization. So these are numbers that are basically very important, and that we realize that not only are serious clinicians that are providing all this information to the literature, but it's also being supported by what we are doing in the clinic. So going back to what we call immediate implant therapy or immediate implants. So there's a number, a magic number, that all these articles, Lazara, Peter Ward, Joe Kahn, Wagenberg, that we have this magic number of about 96% of implant survival with immediates, which is a very, very predictable number. Now, if we go and understand what is the key element, and not only in immediates, but also in delayed, but what is the key element in immediate implant therapy, which is where we don't have a perfectly clear osteotomy prepared on a healed ridge, but we have a fresh socket. So the intimacy between the implant and the bony walls of that socket is not going to be such, because the socket is usually a different shape versus a cylinder that we're putting. So the key is to be able to achieve good primary stability. Okay, that's the very important thing. And obviously we talk about a minimum of 25 to 25 Newton centimeters of insertion torque. Now, Walker published this article in 11, and it's also confirming or basically with the same findings, but it's interesting, he divided these implants that were placed in 3 different groups. And as we can tell from the slide, I'm not going to cover each number in detail, but as we can tell, the less the insertion torque, the less predictability on the implant. For example, if we were in 15 Newton centimeters of initial insertion torque, the survival rate was 86%. And immediately when we were above 30, we jumped to 96%, which is basically, once again, the findings that all these colleagues all over the literature and all over the years have been consistently finding. Before we go into the actual clinical cases, there's one more article or a series of articles that I would like to mention, because it will also contribute to then understanding why is it that we do clinically what I will share that we are doing. And one of these articles is a series of articles, but when we talk about preservation of type 1 sockets, and we do what we call the dual zone therapy, which was originally published by, came up with the idea Dennis Tarnow, and it's that we're actually treating the bone zone, which is the intimate contact between the bone and the implant, and then anything that is happening above the head of the implant or coronal to that head is called the tissue zone. So any tissues above that head of the implant is called the tissue zone, and anything below the head of the implant is called the bone zone. So that's why we have an approach that is a dual zone therapy. And if we can tell in our article on type 1 sockets, what we found is that by placing an implant, a bone graft in the gap that basically happens between the walls of the socket and the implant, sealing that gap with a bone graft without the need of a soft tissue graft, and immediately putting a provisional restoration that allowed us to, as we said initially, preserve the tissues, preserve the gingival architecture, and in this way, minimizing the buccolingual shrinkage, the buccolingual collapse, to about 1/10 of a millimeter, which is obviously almost non-existent. So this is important. This is understanding of approaching these cases conservatively, not going into having to get a donor site for soft tissue, graft for thickening the tissues, which sometimes it might be necessary, but we found that in these cases, with this treatment approach, it was not necessary, and we were still able to manage the shrinkage to about 1/10 of a millimeter. So it's important that by grafting the gap and putting a provisional, we were able to maintain ridge dimension buccolingually. That's number one. And number two, which is the second series of the articles, is what happens at the tissue zone with the peri-implant soft tissue thickness. This is important. This is happening above the head of the implant. It's called what we call the tissue zone, that then when we discuss it clinically, we will see it more clearly. But it's important to understand that by approaching this with a dual zone technique, which where not only we put the bone graft at the bone zone, which is in between the implant and the labial plate of bone, but we also add bone graft above the head of the implant, and that bone graft stays in intimate contact with the tissues in the tissue zone. That allowed us to do what? To be able to get a thicker tissue, the peri-implant tissue of 1 millimeter compared to the average where we were not putting any graft material. So that's a little bit of a starting point as to our foundation and the scientific data as to why is it that we approach the cases, or the few cases that I will show, the way that we do it. Now, let's go into this case in particular. This is Elaine. Elaine, as you can tell, there's a failing tooth number 9 in the United States. It's a left central incisor, failing root canal. And let's go into our first step, which is the extraction. Again, going back to that concept of minimally invasive. Is there any need for us to open up a mucoperiosteal flap to access this root and be able to extract it? The answer is no. There's serious biologic implications if we wanted to do so. Number one, opening a mucoperiosteal flap will lead to us obviously detaching the adjacent papilla, and then, as we know, there will be some shrinkage, and the papilla clinically over time will be a little shorter compared to if we did not open that flap. That's number one. But number two, there's really no need where we have access and visibility, and we have the tools today and the technology to be able to take a root, especially in the aesthetic zone. There's really no need for us to have to be able to open up a mucoperiosteal flap. Let's not forget one thing. Biologically, the implications of opening a mucoperiosteal flap, even though we would open it and close it right away, there's still some time for those blood vessels to have to re-anastomose and re-nurture or re-nourish the bone, the underlying bone. And that takes about 48 to 72 hours. So having said that, the sudden interruption of blood supply when we take the tooth out, that is interrupted from the periodontal ligament, which is an important source of blood supply. And if we, in addition to that, open up a mucoperiosteal flap, so we're interrupting the blood supply from one side and on the other, there's, unfortunately, over time, there's going to be increased bone remodeling due to the RAP, to the regional acceleratory phenomenon that happens the moment that we create the injury. And that will lead to bone shrinkage. And that's why there's enough evidence in the literature that today, and it's very important, this is one aspect of this lecture, that is, at least if there's certain things that we have to take, is to understand that there's no need for us to open up a mucoperiosteal flap to do these extractions. It's completely unnecessary, and as I said, we want to avoid that, and we want to avoid having to deal with that unnecessary bone remodeling that leads to shrinkage. So if, let's say that we have a tooth that has fractured, there's different ways that we can approach it so that we can take this tooth out in the most atraumatic way, never creating forces that go against the labial plate. Let's understand one thing: the labial plate is an anatomic landmark, an anatomic entity that, as we know from dental school and anatomy, is a very thin area of the bone, very papyraceous, very weak. So, and it becomes probably the key element of success in immediate implant therapy, especially, obviously, we're talking about the aesthetic zone. And if it is already a thin element and we are going to leave it exposed by opening up a flap, the fate of that labial plate is going to be, unfortunately, bone resorption. So anything that we can do while we're doing our extraction to preserve the integrity of that labial plate is what we have to do. That's why you see that there's instruments that are going to push this root against the mesial or the distal, and always protecting against so that the labial plate is not disturbed. So in this case, after when we talk about Elaine, we're ready for our extraction. The luxation has been made. As you can see, there's no opening of the flap. And we go ahead and do our extraction. Now, we have our fresh socket. Before we proceed to plan our implant placement, it's very important to understand one thing. We have to do a diagnosis of the type of socket that we have. Sometimes we think that we have a type 1 socket, and suddenly we do our surgical curette and we find the fenestration, we find adhesions. So it's very important. It takes 30 seconds to understand and to check the integrity of all the bony walls. Now, that doesn't mean that we would have to change the course or the direction of the treatment, but it's very important for us to know, because maybe we might have to do something extra in case there's problems with the integrity of the bone in the buccal area or in the interproximal. So, having said that, once we check and we confirm that we have a type 1 socket, then we start thinking about our implant placement. And this is what I call the three-dimensional alignment. Placing an implant, sometimes I heard, well, you know, the immediates are the easiest ones because obviously you have the socket there, so you cannot miss. Well, actually, you can miss, and you can miss by a lot. And the socket is not that forgiving, and it's very tricky. Sometimes the apex is not where you want to be. Sometimes you want to be behind the apex. And sometimes certain denser areas of bone might guide your drilling process, and suddenly you find yourself that where you started is not where you're ending, because usually in the aesthetic zone, in the maxilla, there's the path of least resistance is towards the buccal, because the palate is a very, very thick bone. So that can usually at the tail end bring either your drilling against the buccal, or even at the moment of implant placement, push your implant out, which is not where you were when you were drilling. That's why it's very important, and you have to be paying attention in all these moments to achieve proper three-dimensional alignment. And three-dimensional alignment, as the three-dimensional word says, is not only buccolingually, but it's also mesiodistally. That's more that we will discuss shortly. So, from what we've been doing over the last 10 years routinely is we are always aiming for a screw retained restoration. And we're always wanting that screw or that access fold through the screw coming out through the cingulum. And to do so, to be able to achieve that, as you can tell in this diagram, we try to create a notch and bring the implant bodily against the palatal wall. So that allows us to have a facial gap that becomes a chamber which will contain bone graft. But the thicker the chamber, the more predictable the case is. The reason why is because as the labial plate is still thin, we want to make sure that over the years, once that bone graft condenses or forms into bone, it becomes thick bone in the coronal aspect, which basically stands the test of time. And those are the cases that we come 10, 12 years later, and having thick bone when we take our CBCT scans are the ones that look the best. So as you can tell, we're bodily bringing the implant inside to try to achieve the access fold through the cingulum of this future restoration. Now, three-dimensional alignment is not only, as I said, buccolingually, mesiodistally, but also vertically, how deep we go. We're not going to cover all these papers, but the work, the extensive work from my friend Thomas Dinkevicius out of Lithuania, and that has described the importance of the soft tissue thickness when we talk about implant therapy, and how important the thickness of the tissue can be in terms of what leads to bone remodeling or crestal bone remodeling. So what we learned from this is that we have, especially in immediate implant therapy, where we don't see sometimes clearly the bone crest, but we see the soft tissue crest, that's our reference point. And we place our implants from the soft tissue crest, not the bone crest, which is what we can see 3 millimeters at the very least below the soft tissue crest. And why is that? Because in a type 1 socket, the labial plate usually starts 3 millimeters below the pharyngeal margin. So at least we have to be 3 millimeters below the soft tissue crest at least 3 millimeters, which is where the bone starts. That's why sometimes in the x-rays you will find, or you will get a feeling that your implants are too deep, but actually your reference point, it's very important, your reference point is the buccal area, the soft tissue crest, and at least 3 millimeters, at least 3 millimeters below that crest. So let's confirm that when we are placing our implant, as we say, we're trying to get our implant against the palatal wall. We're leaning against the palatal wall, and this is when we start our provisional restoration fabrication. Try to aim our access hole in that cingulum area. Once we start working with this provision, and we'll just see the steps in a minute, we connect a shell, which is a provisional crown, to a temporary cylinder, usually PEEK, polyether ether ketone. And once this is connected, again, a critical piece, once the PEEK is connected to the acrylic crown, we remove the acrylic crown and the PEEK, and we finish the provisional restoration outside the mouth. So in other words, we're not trying to capture any margin with acrylic intraorally. We're doing everything, we're finishing everything extraorally. And as you can tell, all these voids in between the PEEK and the abutment are filled with acrylic, and we create our nice contour. At the moment that we're making our temporary, what are we doing? We're doing diagnosis, and we're double checking our three-dimensional alignment and if it's good or bad. And this is the time, if we see that in the provisional, this crown is not going to fly, this is the time that either we change the position of the implant or we unfortunately delay the case. So again, in doing the provisional, we are doing diagnosis. Good emergence profile, buccal, lingual, we use custom staining on these provisionals. And this is Elaine's provisional. Now, once this provisional is checked and approved, slightly in lingual version, we have to manage occlusion. The provisionals these are not immediate load cases, these are immediate provisionals. So these provisionals don't hit against the opposing teeth. In other words, they're free of contacts in centric and eccentric movements. There's no contact whatsoever in parafunction. And we try to tell the patients, obviously, not to bite on anything hard on that tooth for a few months. So once the provisional is checked, we unscrew the provisional and we address what? The bone graft portion. And this is where we go back to the dual zone socket management. And as I mentioned before, the tissue zone, as you can tell in the diagram, is anything that happens above the head of the implant, and anything that happens below the head of the implant is the bone zone. So we will treat those two areas in particular with bone graft. So we're going to graft the area where the bone zone is, and usually what we do is do small particles, cancellous, 250 to 500 microns bone graft particles. And this is what you see, small particle, mineralized cancellous allograft. And as you can tell, not only the bone graft goes against in between the labial plate of bone and the implant, but it also goes almost flush to the soft tissue, to the free gingival margin. That's why we put a 5 millimeter height cylinder, temporary cylinder, healing abutment, and we bring the graft almost flush with that healing abutment. Now, the excess of that bone graft, once we screw back the provisional that we have just made, will basically be removed with an explorer. But it's important that not only the bone graft is staying in the bone zone, down deep where we want it, to preserve that buccal lingual dimension, but also in the tissue zone, as I mentioned, quoting our article, that allows us to have a thicker peri-implant tissue in average of 1 millimeter compared to the control. So we're grafting not only the bone zone, but the tissue zone. Those particles get pushed and encroached against the soft tissue, leading to no inflammation whatsoever. If there's any excess of particles, the body's gonna get rid of those through the sulcus. And healing abutment is removed and provisional crown screwed back in position. So you can tell from the picture that the bone graft is not only on the tissue zone, on the bone zone, but also on the tissue zone. And that excess, once the crown is screwed in, and that's why it becomes so important, a screw retained provisional, is because by the action of screwing the crown in, that bone graft material is compacted against not only the bone zone, but the tissue zone. And that area stays basically allowing the soft tissues to be slightly thicker in comparison with the control, again, in an average of 1 millimeter. Now, it becomes also very important that this provisional becomes a prosthetic socket seal. So what is the provisional doing? It's a few things that it's doing. Number one is preserving the gingival architecture. So in other words, I'm basically restoring with the tooth, with the shape of the tooth, like the tooth that was there. So the gingival margin and the gingival architecture, the way that I found it, I'm actually preserving. I'm not inventing anything. I'm not under contouring or over contouring anything. I'm just doing what, basically replicating what was there. Do you remember in that slide, preservation, do not disturb? We're basically putting back what we took out. So that's not only one action of the provisional, but also protecting the bone graft and the blood clot. So there's a few chances of having a dry socket. This blood clot, together with the bone graft, becomes a stable area that is protected, like having a socket seal, like a Band-Aid, that is not going anywhere, and is basically keeping everything contained. So it contains the biomaterial, it protects it, and it preserves the architecture. This is our PA, the X-ray of the implant placed, and this is the provisional. This is the day of the surgery, provisional placed. And this is Elaine a week later. And we can tell by being minimally invasive and trying not to disturb the tissues, these procedures, there's a beauty of these procedures is that they come with absolutely no swelling. Obviously, there's no elevation of the mucoperiosteal flap, so there's no swelling. Everything seems to be very clean. And this is not like just the one case that came out right by luck. We've been doing this consistently. And type 1 cases become a very predictable approach. And that's why we talk about predictability. So this is 1 week. It increases tremendously patient satisfaction. This is Elaine at 2 weeks. And let's take a look at Elaine at 4 months. And take a look at 4 months, how we were able to not only preserve the architecture, but even buccolingually, the aspect of the tissues. Now you can tell that the provisional is slightly thinner on the lingual, in the palatal area. That's obviously to manage the occlusion. So this was day 0. This is when we're ready to uncover. This is 7 months. 7 months, complete maturation of the tissue. We didn't see Elaine for a few months. We would have liked to uncover that at around 5 to 6 months. We didn't see her, she was in college, so now she's back and we have our perfectly healed and stable peri-implant tissue and the implant per se healed inside the bone. In this case, again, we use an implant that has a built-in platform switch, and you can tell how, even based on the works of Ron Nevins, how the healing takes place around a platform switch implant, and how we have soft tissue almost on the platform. That basically leads to more stable bone around the crestal area. So we're ready for our impression. Final impression is made. This is our master cast. And then our ceramist, Adam Mieleszko, who is basically in charge of our in-house lab, is the one that was able to fabricate this metal ceramic restoration. We normally gold plate these metal ceramic restorations. As you can tell, there's no translucency of any grays. It's important to know that yellows exist in the mouth, blacks or grays do not. That's why it becomes critical. But we are always ahead of the game when we know that by grafting the tissue zone, we make those supra or those peri-implant tissues thicker in average. So that's always an insurance policy that we have. So there's all the summation of little steps that lead to a good clinical outcome. And this is Elaine's final restoration. These are the periapical radiographs, and as you can tell, this is Elaine before and Elaine after. And going back to that slide initially of preservation of the tissues that we found prior to have to take that tooth out. So this beauty of the soft tissues around this implant was basically not created by anybody or by us. It was created by nature. And we just respected what was there, preserved it, didn't change much, and we were able to keep it during the course of the healing of the implant with a good provisional, and now with a good final restoration. Another case, this is Ben. Ben, unfortunately, history of a trauma to his left central incisor. The very interesting way of fracturing the tooth. And look at this happened with the baseball bat accident. And it's interesting to see how even we were able to document the nerve. When we did the extraction, we see the height of the fracture, we see the aspect of the main fragment, and obviously the other portion of the fragment of the tooth still to be extracted. And the same thing that we did with the lane, and this can become repetitive, but by repetition is that we convey the idea. We're sticking to a protocol. We're sticking to a protocol of preserving what we find, not having to open up a flap to remove these teeth, being as careful as possible, and what we call in doing an atraumatic extraction. We have very fine diamond burrs that we can go around. We can have the piezotome. We have different tools in our armamentarium that allow us to take this route in a very clean and conservative way. And this is what we did. And once the root was extracted, once again, stress on the three-dimensional alignment. We place our implant, aiming for the access hole in the cingulum. When we fabricate a provisional, there has been these preformed implant shells or sleeves. It's like having preformed iron crowns, but just for the gingival portion of a future provisional restoration. They're very handy, very helpful when fabricating implant provisionalizations. They're basically simplifying the way that we fabricate the provisional, because we don't have to capture the margin. If these little shells have the size of the socket, different sizes, small, medium, large, you just place one as if you were placing a crown, and then the whole moment of capturing those soft tissues is done in like 1 second instead of having to do it by brush and acrylic powder and liquid. So tooth-specific implant shells. Again, one polyether ether ketone temporary abutment, our acrylic crown or shell, and also the preformed implant shell. So how do we work with this? Well, we find the shell that has basically the shape of a central, left central incisor. We fit it right there. And then what we do is we tack it with acrylic to the peak. Once we do that, it's like having already in 30 seconds, a customized healing abutment. If you shave or if you cut off the peak, it stays as a healing abutment that is customized to bend. It's not just a generic or a stock healing abutment. But obviously, once we have good initial insertion torque value, and we are about 30 or 40, we go ahead and we fabricate our fully anatomic provisional. And this is what we're doing right now. So then once we connect the shell to the peak, to the crown, there we have all the components connected. As you can see on the margin, on the screen from the side, you can clearly see the shell. You have the right emergence profile, then you have the crown per se, and the excess of acrylic. We seal all the voids, we trim the excess of acrylic, and then we have our fully contoured provisional crown. What is it that we have to do? Before we finish the provisional part, we have to screw it in position, make sure that occlusion is free, centric and eccentric. Basically, there's no contact against that provisional. zero contact in centric and eccentric movements. And once that is checked, we unscrew, we put our healing abutment once again, and we pack our bone graft where in the gap in between the implant and the labial plate, where not only in the bone zone, but in the tissue zone. As you can tell, there's bone graft material above the head of the implant, exactly in the way that we did it with Elaine. So this is Ben's provisional. This is Ben a week later, 4 months, and we're ready for impression. Ready for impression, fabricating the same. We're capturing the soft tissues, solid cast, and once again, Adam Mileshko delivering the goods with a beautiful metalloceramic restoration. This is insertion, and this is Ben's final crown in place. Couldn't be happy with the soft tissue aspect. We couldn't be happy with everything actually on this restoration. These cases were restored by my partner, Steve Chu, which is always a pleasure and a privilege to work with. And this is a very important aspect of the lecture, which are usually the questions that we get about the concerns. Do we have any concerns when we're doing these cases? And the answer is completely yes. Actually, we were able to narrow them to a few things, which are three mainly. Number one, the labial plate of bone, as we mentioned, which is a critical piece in these restorations. Number two is the interdental papilla. And if you think about all this is related to what? To the three aspects of the three-dimensional alignment of the implant. The labial bone, if you're way too far buccal, the interdental papilla, if you're towards the mesial or distal too much, closer to the adjacent tooth, or the apical perforation. That means that if you're going way too deep or in this direction, you might, at the expense of coming out with the access hole through the cingulum, perforate apically. And thank God today we have CT scans when we do post-op implant therapy that we can confirm that we are within the housing of bone, but a lot of times or before we didn't have them, and a lot of these apical perforations probably would go undiagnosed. So clearly a labial plate in a case like this, or the proximity to an adjacent tooth, which will basically in that case make that papilla disappear, or in a case like this, the problem with an apical fenestration. Maybe take a look. What happens when there's no labial plate? You start having the grayness, the complaint that typically we get from patients. Like Esposito described in '93 about proximity of an implant towards the adjacent tooth, we can tell the problem with the dental papilla. And that's why we're working, and this is the beauty of having the industry basically help us. We're working with implants that are basically site-specific for this particularly challenging case. We have extraction sockets and heel ridge. You can tell that the amount of bone is basically higher the more apical you go, and less in the more coronal aspect. Obviously, against the shape of our implants. So the industry was able to come up with a different design for certain clinical situations that we find very interesting and with great clinical applications when the case really requires it. So it's a concept of a body shift concept, which works on different diameter and shape of the implant. So it's not a platform switch implant, it's actually a body shift concept if you pay attention. And it's basically having an implant that has a very aggressive thread design where we need it, which is where the most apical area, very aggressive thread design. And then suddenly the implant, if we need diameter where we needed it, which is further apical, but then we need to have less of a diameter in the areas that are the most critical, which is where? Against the labial plate, against the adjacent teeth. That's where the implant diameter narrows, and it's called the body shift concept. So we have a transition area and a narrower coronal area. And where is it that we would need them? Clearly, if I can get away or I can do my implants like in cases like Elaine or Ben, I will obviously use the regular or the conventional tapered implant. But in certain cases where we can have anatomic compromises, limited dimensions, or even at what we call a rescue situation in where we have to fix this problem or an implant misplaced, not coronally, but with a problem apically, then this implant design can come handy. So we have, as Prey described, that there's an influence of bone thickness, which I mentioned before, that the labial plate is so thin that long-term we want the bone there in the coronal aspect to be thicker. So by having an implant that narrows in the coronal aspect, creates this, what we call this facial palatal chamber, bone chamber, where we can graft the gap becomes a little bigger, and then we can pack more bone graft and have more thickness of bone in between the body of the implant and the labial bone. So 1.5 to 2 millimeter is considered to be ideal and stable over time. And in the same way, this happens with interproximal, like a positive 93 described. So if we are able to narrow interproximally that implant and we got good initial stability from the apical portion of the implant, then it allows us to be able to create that lateral or interproximal bone chambers, bone graft, and basically in that way we are staying further away from the adjacent tooth, thus being able to preserve the interdental papilla. Now, another thing which is a beauty, and not only in this particular implant, but there's a few companies that are doing this, especially for certain implant, certain anatomic sites, is what? A coaxis component, which is basically have an offset of 12 degrees at the coronal aspect of the implant. So that immediately allows us some leeway where we have that coaxis and it will slightly buckle with the implant placement, we are still being compensated by 12 degrees offset of that main axis of the implant with another axis. So remember this drawing that we had on this on our conventional implant placement. Well, guess what? Now with these implants, if we are aiming, we're not aiming as much as the cingulum because we have this slight insurance policy. So we can go ahead and aim at the incisal edge. Why? Because we have our implant placed like that, but we still have our 12 degree offset allows us to have the access hole through the cingulum. And let's confirm this, or let's see a clinical case with one of the implants that was very challenging. We would have to have done it with a conventional straight body implant. So this is Genevieve, a failing endodontically treated tooth. And this was 20 years of success until the tooth failed. As you can see, confirmed the fracture with the CBCT. And if we wanted to place our implant, again, following our protocol, we would be too close in the apical area. So what we decided is to go with one of the coaxis implant. It's interesting that there's some there are companies that do coaxis implants without the need of that blob of apical wider body. Again, I think that the coaxis is incredibly handy, especially in certain cases of maxillary implants in the aesthetic zone. And this is exactly what we decided. So once again, the same approach in terms of extraction. We're almost borderline of having some buccal labial plate compromise. So we were able to do our extraction. And as you can tell, you see that now in this type of implants, we are drilling more with our drill towards the incisal edge. We're not really bodily leaning against the palatal wall. We're basically pointing at the incisal edge, which you have a clear or like a more evident anatomic landmark, which is the incisal edge of the adjacent teeth. You can see the osteotomy made, and this is the placement. Now, very important, that there's a notch, there's different nuances as to how we place these implants, because obviously there's a dot that has to be towards the buccal because you want the access hole not towards the buccal, but towards the lingual. So it has to be perfectly precise. These are the drivers that you end up tightening the implant. And then once again, the same concept, an eye shell to fabricate the provisional restoration, the peak abutment, the acrylic crown. And once again, we are sealing the voids with acrylic, trim the excess, polish, clean, and what we will do, non-occlusion loading, we check, we approve, free of contacts and labial version of the provisional to avoid from those occlusal contacts that we don't want. And once again, we're doing a dual zone, dual graft materials. Right now, we're seeing that we're using minerals or mineral cord cancellous bone for the bone zone, but we're for the tissue for the bone zone, we're using bios and then cancellous bone for the tissue zone. So we want in the bone zone and a bone graft material that is going to stay over time and actually not go anywhere. It's going to not resorb, but slowly resorb it over the years. And we want in the tissue zone some material like the minerals, like the cancellous bone, the small particles like 250 to 500 microns, that eventually there's any need, they will resorb, or they will be eliminated in excess by the body. So the bone graft material in place, once again, we screw back our provisional, we remove the excess, and here we have our prosthetic socket seal. This is the implant place with the immediate provisional, and this is Genevieve at 2 weeks. And what looked very, very inflamed and traumatic the day of the extraction, the healing is basically within normal limits. This is Genevieve at 5 months. And this is the time for us to make our final impression. Once again, solid cast, capturing the soft tissues in the best and the most accurate way that we have. And once again, Adam Yaleshko doing our screw-retained metalloceramic restoration. In this case, turned out to be really beautiful. You can tell the handiness and the interesting concept about that coaxial. Those 12 degrees basically allow us to not have to be so much against the palatal walls, and also by having an implant that tapers towards the apex, we are able to avoid those concavities close to the apical area to avoid the apical perforations. So this is where we started with the sounding of 4.5 millimeters. It was almost borderline between a type 1 and type 2 socket. We ended up treating it as type 1 socket. And you can tell the bone graft and the xenograft. This is the area that was completely grafted, and we can tell how that stayed, and we still have that thickness that we are aiming for once the healing took place. So this is Genevieve at a 2-year recall, and we can still see that there's 2 millimeters or over 2 millimeters of bone in the most coronal aspect, which is exactly where we grafted it. Don't forget that we have almost 4 millimeters of bone that was dehisced because of the fracture. So all that has been bone graft that has turned into bone successfully. And this is how the bone is staying there over time. So just to wrap it up, as we said, the dual zone therapeutic concept, we graft both the bone zone and the tissue zone. That allows us for minimizing the buccal lingual collapse or the buccal lingual shrinkage to about 1/10 of a millimeter. And by grafting also the tissue zone, we are actually improving the thickness of the supra-implant or the peri-implant tissues to about 1 millimeter compared to the control. The beautiful of this is where we're basically mimicking the submergence contour of the extracted tooth. We're not really under contour or over contouring. We're basically wanting to make sure that whatever was there, we are preserving. We're not doing anything except for just replicating or restoring the anatomy as it was. And as we know, the platform switching with proper implant depth does create a biologic seal for longitudinal tissue stability, as we saw in Elaine's case. So having said that, it was a lot of material, but I want to thank everybody. Thank you again, the ICOI. That's my email. You know, I'm available with any questions, but we have an extra few minutes. Just like we were 5 minutes, 6 minutes after late, so I'd be more than happy to address questions. Adi and Tara, you let me know.
Thank you, Dr. Sarnachiaro. Can you see the questions at all? Oh, there's.
I do not.
Look, push the button on the top of your screen on the right. There are a few questions. Do you want me to read it for you?
Hold on.
You see that?
No. Just, oh, hold on.
On your screen, on the top, right?
What do you consider a class 3 socket in position 15 or 2? Do you consider a J block with screw stamping or something else? Yes, I don't have, this is a response to David. David, I don't have experience with J blocks, so I cannot really tell you anything about the use of those. If I have a class 3 socket, normally what I do is let it do the extraction, let everything heal, and then logically I have to build the bone wherever I need it, but I would not consider doing an implant immediately into a situation like a class 3 socket in position 15 or 2. What type of bone did you use in the graft? In the graft, as I said initially, some of the cases, all the bone graft that was used is small particles, 250 to 500 microns of cancellous bone, like really basically an allograft. Now, over the last few years, what we've been doing is change or adjust the protocol so that we use in the bone zone a xenograft, same size of particle, and that is contained between the labial plate of bone and the implant. And then in the tissue zone, we still use the same allograft material. Immediate implant placement in the upper and lower molars? The answer is yes. There's a protocol to those. I just want to reference an article, and then that's obviously a different lecture, but for Richard Smith that he published a few years ago, one of my partners, and he basically has worked on the classification on immediates for molars, and there's types A, B, and C of sockets, depending if you have the septum, if you just go and wipe the septum out. So there's a different protocol that I will not really address right now. Same, what's your opinion on partial extraction socket shield technique? I think that the partial extraction socket or shield technique, I know the proponents very well. I think they're phenomenal clinicians. I think that it's great when it works. And I think that, you know, as every technique, there has some potential drawbacks, but overall it can be done. If I feel that I can get these results in a predictable way, the way that I get or the way that we get with my group, I actually don't find much of a need or an application, but I've seen even dentists over the course of probably, you know, since I joined the practice, maybe make 2 of the PETs, the partial extraction socket shields. And again, not something that is routine in our office. When placing your implant, you place a graft in the socket and then do the final placement so that the graft can have a more intimate contact with the body as it is extruded. The answer is no. I place the implant first, and the socket, the graft is placed basically in between the implant in the gap that is left. I really am not relying on the graft for integration. I don't need more of an intimate contact. The integration is happening basically from the initial stability of the implant that was that we were able to achieve. The graft is just basically for aesthetic purposes and to decrease the buccal lingual collapse. So the answer is the implant is placed, and it's not moved at all, and then the graft is added later. And we use those small instruments, condensers, that basically condense the particles all the way down to as much as we can. But all that area, wherever that you don't find a particle, you will find a blood clot that will eventually turn into bone. What are your thoughts about partial extraction and immediate implant placement? I just addressed that. Which bone graft material gives better predictability in the labial defect situation? We just mentioned that. If my implant is, thank you very much, if my implant is placed at flush crestal bone level, I only have a soft tissue volume of 1 millimeter at the top. Would I need to do soft tissue graft to improve the biologic seal? Probably yes, or probably bury the implant more, if possible. So leaving it as is in that clinical scenario that you're describing is probably not the best outcome. I think that I would like to, for sure, you're gonna need at least 3 millimeters of soft tissue. If not, you have to already negotiate that you're gonna lose crestal bone. So if the implant has been referred to you and it's already placed, that's a problem. If you're at the surgical moment and then you're able to bring it deeper, that's what I would recommend. How or what instrument to pack bone in narrow gap without touching the titanium implant? We usually have these, sometimes we have these plastic tools, but even the old amalgam condensers with a very thin tip, we're actually not touching the implant. We're just basically staying with the instrument against the labial plate and the soft tissue. We're not really going that deep down. We're just bringing it as much as you can. And once you start feeling resistance from the particles per se, that's where you stop. But you doing an immediate placement, there's no primary stability. If there is no initial stability, we unfortunately delay the case. And there hasn't been that many cases that with all the different options that we have, even different implant designs, we are usually able to achieve good initial stability. The other thing that you can do, if you're not going to be doing the cross, is something interesting, which is at some point I was saying you can use either an ISO or fabricate a customized healing abutment. Let's say that you are with 25 Newton centimeters of insertion torque and you don't feel comfortable, you cannot manage the occlusion, you feel that the patient is going to bite on anything, and you don't want that implant to fail. So what you can do is really basically stick to the same start to finish protocol, and instead of doing a fully contact provisional, you do a customized healing abutment. You did everything exactly the way that I did, except for just having a patient with a beautifully looking temper. But if you do a customized healing abutment, you're preserving the architecture, you're protecting the bone graft, you're doing everything, and you are ready for the restorative dentist or you to make the impression. And if you do a customized healing abutment, then you can give the patient an SX retainer with a temporary or like a Meriden bridge or a flipper. How do you handle an apical perforation if you do an immediate implant? That's a long discussion. If the apical perforation is such that it has a certain dimension that you know as a fact that it will not create migration of the soft tissue just by adding some bone all the way deep area, you can just get away with it. Otherwise, if you feel that it's a fairly considerable sized apical perforation, what you can do, you can do a semilunar incision and open a flap up apical to the keratinized tissue, access the fenestration, graft through the buccal, place a collagen membrane and suture the semilunar. So it's called parched semilunar incision, and just finish the case.
I want to thank you again for a wonderful presentation. I want to remind everybody that the lecture will be available on the ICOI YouTube channel. And I hope to see you again. And Guido, I hope to see you in person as soon as possible.
I look forward
and say hello to everybody.
Thank you so much.
Have a wonderful evening, all of you.